Hi, I'm Adie Viljoen. I work in the United Kingdom where I'm a consultant, and I'm going to present poster 773. This is the efficacy and safety of semaglutide by baseline BMI in the SUSTAIN 1 to 5 and 7 trials. So we looked at the efficacy and safety of semaglutide in these trials, and I've been fortunate to be involved in these studies. To provide a little bit of context before I share the results with you, semaglutide is a once-weekly injectable GLP-1 analog, and this is licensed at 0.5 milligram and 1 milligram doses. And semaglutide has been shown to be superior in terms of HbA1c reductions and weight when compared to placebo, and that's the SUSTAIN 1 and SUSTAIN 5 trials, and active comparators, and these are the SUSTAIN 2, SUSTAIN 3 and SUSTAIN 4 trials. And here I'll show you the active comparators, being first these color codings. The green you can see is SUSTAIN 4, which is insulin glargine. The yellow is exenatide ER, and the gray is sitagliptin. These active comparators, and the other active comparator was the SUSTAIN 7 trial, where semaglutide was compared to dulaglutide, both at a low and a high dose. And why did we look at BMI? Well, we know that weight can influence drug efficacy, so that's the first point, and we want to see whether there are any outliers that certain BMI groups benefit more. And because we saw so much superiority in terms of semaglutide compared to these active comparators, are there any actually other drivers within BMI subgroups that may explain this? So what we did is, our methods were, we divided all the patients up into various BMI subgroups: BMI less than 25, 25 to 30, 30 to 35, and greater than 35. And then we looked at the baseline HbA1c change and at the end of treatment. Here we can see in table 1 the baseline characteristics and the demographics of the trial, and you see patients are very well matched across these SUSTAIN 1 to 5 and 7 trials in terms of diabetes duration, HbA1c, body weight and BMI. And you can see the BMI around 32, the body weight around 90 kilograms, the HbA1c ranging from about 8.1 to 8.4, diabetes duration ranging from 4 to about 9. The SUSTAIN 5 trial was an add-on to insulin, so that was a longer duration of diabetes, and the age ranging above 50 to about 60. So we assessed now, as you can see in figure 2, the estimated change of HbA1c by baseline BMI. On the far left, you can see all subjects, and then you have the various BMI subgroups: less than 25, 25 to 30, 30 to 35, and 35, above 35. And here you can clearly see the dark blue bars are semaglutide at the high dose, that's 1 milligram, the light blue is 0.5 milligrams, and then SUSTAIN 2, here we have the active comparator to sitagliptin, extended release exenatide, SUSTAIN 3, and insulin glargine, all showing superiority within all of these subjects, except this one place where we saw insulin glargine at the low BMI, that semaglutide was not superior. And that's one outlier, but I think it's important to look at the number of patients that were involved, very small numbers, 26, 29, so obviously fewer patients at the low BMI subgroups. If we take a look at table 2 and we look at the adverse events by BMI, you can see that the overall adverse events were actually more or less similar, slightly lower for the comparator, bearing in mind that 2 of the trials, SUSTAIN 1 and SUSTAIN 5, were trials where the comparator was actually a placebo. And the other interesting thing that we did see is GI adverse events. If you go down here and have a look, you'll see patients with BMIs that are low have a slightly higher GI adverse event, 47% or about 50% on semaglutide 1 milligram, and this decreases as the BMI goes up. And I think this helps us in terms of clinical practice, that when patients have perhaps lower BMIs, we might want to start at lower doses. So what can we conclude from this study and this subgroup analysis which we performed? We can conclude that irrespective or regardless of baseline BMI, semaglutide at 0.5 or 1 milligram outperforms the active comparators and, of course, also placebo. So there's no real difference irrespective of what the patient's BMI is, and I think this will really guide clinical practice. And lastly, I want to acknowledge my co-authors, and they are listed here, as you can see, and all the other, perhaps even some of you were involved in some of these trials, and also acknowledge Novo Nordisk, who sponsored this. And lastly, I want to thank all the patients that were involved in these trials to make this data possible, to help us make clinical decisions. And thank you for listening.